So I'll try to cover this rather extensive topic by just quickly briefing you about all the diseases and going through the video and the photographs of each one in a short while. Vitreoretinal complications of uveitis can be seen both in the infectious form of uveitis as well as in the non-infectious variety of uveitis. These complications are, however, more commonly seen where the infectious form of uveitis is concerned. For example, in patients with acute retinal necrosis, retinal detachment may be seen in as many as 75 to 85% of the patients. In ARN, the contraction of the diseased vitreous, this creates large retinal breaks at the border of the involved and the uninvolved retina, and this subsequently leads on to retinal detachment. Medical therapy should be aggressive. This is required to limit the progression of disease as well as involvement of the other eye, but unfortunately it may not reduce the high incidence of retinal detachment seen in these cases. RD occurs most commonly 1 to 2 months after the acute period of retinal necrosis. Once retinal detachment is seen, you need pars plana vitrectomy to resolve these issues. Lensectomy is required in nearly all the cases, and as you see here, there is some fishnet kind of retina which is atrophic, and this may need to be excised in form of a 360-degree retinotomy and followed by a long-term tamponade. Silicone oil is our tamponade of choice in these cases. The specific issues which you may come across while you're operating these cases are that because of the large multiple breaks, the incidence of PVR and vitreous traction is very high. So the rates of post-operative complication like macular pucker and recurrent retinal detachment is also high. In contrast, going to CMV retinitis, it is more commonly seen in actually immunosuppressed individuals with no or minimal vitreous inflammation. The mechanism of break formation and retinal detachment remains similar. RD is very common, however severe PVR and vitritis is usually unusual in CMV retinitis. Exudative retinal detachment may also be seen in extensive forms of CMV retinitis, and it needs to be differentiated from a reg retinal detachment. Management again remains medical as well as surgical. Surgical management is in form of pars plana vitrectomy again with induction of posterior vitreous detachment, and this atrophic retina here needs to be excised and cut. You can see the underlying choroid and RPE, which is rather unhealthy. So after excision of this retina, and you end up having nearly a 360-degree relaxing retinotomy, which is then settled by using perfluorocarbon liquids and followed by laser photocoagulation and silicone oil injection. Visual prognosis in spite of heroic surgery may remain poor because of optic atrophy as well as macular pathology. CMV uveitis picture may be somewhat modified in patients who are on heart, and you may see increasing incidence of PVR as well as extensive inflammation, so much so that they may need steroid medication. Intraocular cysticercosis, best diagnosed by direct visualization of the cyst with a dense white spot. And it is the location of the cyst which decides what pathway for removal and what is the procedure you will undertake to remove the cyst. Here you see there is the subretinal cyst which is being removed externally. It requires accurate localization of the cyst using indirect ophthalmoscopy, which is followed by forming an external drainage site. Once the cyst wall has been exposed, you can use a cryo tip to remove it. Here you see the cyst pops out. There is drainage of subretinal fluid. You close up the drainage site to prevent hypotony and then support this area with a buckle. So another example of subretinal cyst which is removed using pars plana vitrectomy, PVD induction, and a retinotomy is fashioned here. Subretinal saline is injected to mobilize the cyst. Cautery is done. Subretinal cryotip is used to remove or extract this cyst. Size of the drainage site should be enough to deliver the scolex. The rest of the cyst sort of manages to come out on its own. Another example of an intravitreal cyst. The adhesions from the vitreous as well as the retina are cut. The cyst is now free and mobile in the vit cavity. Now you can increase the size of your sclerotomy, which should be enough again to deliver the scolex, and the cyst is engaged with the cryotip and brought out of the sclerotomy. Another example of an intracameral cysticercosis. This can be easily removed by making an entry into the AC and mobilizing the cyst. Then this is followed by suction. A small cyst rapidly comes into a 26 gauge needle. However, in spite of a good surgery, your post-op results may not be so encouraging, especially in subretinal cysts, which will be accompanied by a lot of subretinal exudation and inflammation. Few specific issues we need to take care of is that anti-helminthic treatment is not always needed, and whenever needed, intraocular cysticercosis should be first removed before you start it. The cyst can be removed piecemeal as well. Only it needs to be followed by a thorough lavage and post-op steroids to control any excessive inflammation. An example of intraocular nematode, which if it is in AC, it can be easily removed. And you can see it is a live intraocular nematode. However, if it is in the subretinal space, it may not be so easy, and to remove this, people have tried laser photocoagulation around it to limit its movement. Toxocarisis is characterized by posterior and peripheral retinochoroiditis as well as tractional retinal detachment. If combined retinal detachment is seen, it will need surgical intervention. Here again, surgical intervention is pretty heroic. You need lensectomy, you need vitrectomy. These extensive membranes need to be removed. But in spite of your best surgery, you may not be able to remove them in toto. So the peripheral residual vitreous traction is supported by an encircling band and followed by fluid gas exchange and silicone oil. In non-infectious form of uveitis also, vitreous surgery may be essential. For example, if the patient presents with the vitreous hemorrhage secondary to Eales disease, you can do a 23 gauge vitrectomy to take care of the vitreous hemorrhage. The aim here is to clear the media, followed by good laser photocoagulation, cauterization of bleeders to prevent recurrent vitreous hemorrhage. If it is seen by extensive fibrovascular proliferation is seen, you may have to do delamination and dissection of these membranes to reattach the retina. Rhegmatogenous retinal detachment in uveitis can be dealt with by routine means. However, a few things which you need to remember: encirclage can be beneficial in these cases, and post-op PVR and exacerbation of uveitis needs to be taken care of by steroid cover. Most of the times, exudative retinal detachment responds to immunosuppressive therapy. If not, pars plana vitrectomy with retinotomy to drain the SRF can be done. Hypotony, we had some very good slides and information earlier in this session. So just briefly, that we do have the dissection of these membranes, but they do not generally pick up the function because the underlying ciliary processes are very atrophic. GRA may also need pars plana lensectomy because that can be an effective way to deal with the cataract. The complicated cataract in these cases may sometimes be so hard or calcific or membranous that you may not be able to remove it so easily, and if you have it falling down, you actually may have to crush it between two instruments to fragment it and then bring it out. A good perioperative control of inflammation is a must in any kind of cataract extraction in patients with GRA. Another example of a patient who had extensive corneal decompensation, peripheral anterior synecdoche formation in a patient of GRA. So under viscoelastic cover using a spatula, all these peripheral anterior synecdoche are broken. The iris has to be actually mechanically pulled out of the angle at times to restore or to open up the angle. Another example where intraocular lens has caused lots of dense membrane formation, and you may need to use gray scissors through the pars plana to create an accurate, adequate opening to clear the visual axis. Last but not the least, pars plana vitrectomy may be useful for obtaining intraocular fluid for evaluation and diagnosis of conditions like lymphoma. 23 gauge vitrectomy can be easily done in these patients. However, you need to remember that the chance of hypotony, which is usually seen in uveitic eyes, may be higher if you use a 23 gauge vitrectomy. Also, we saw that more common use of scleral buckle in these patients may actually limit the number of times you could use a 23 gauge vitrectomy. In conclusion, pars plana vitrectomy is important to correct the structural complications. However, an integrated approach is a must with your uvea colleagues as well as the internists to effectively treat these patients. Thank you.